Welcome to our video on benign trophoblastic disease. Let's get started. Here's our overview slide. You can see that benign trophoblastic disease is split into complete molar pregnancy and partial molar pregnancy. Let's start with complete molar pregnancy. With regards to this topic, we'll be discussing the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. So let's begin with the definition. Complete molar pregnancies are an abnormal proliferation of syncytial trophoblasts. They result in the replacement of normal placental tissue with trophoblastic tissue by hydropic placental villi. Complete molar pregnancies may also be referred to as complete hydatidiform moles. Complete molar pregnancies are a result of an improper fertilization event. They occur when an empty ovum with no maternal genetic material is fertilized by a haploid sperm that then duplicates. They can also occur when an empty ovum is fertilized by two sperm, but this is relatively rare. These fertilization events result in a zygote with only one paternal genetic material, and typically the karyotype of this zygote will be 46XX. This in turn leads to the proliferation of trophoblastic tissue and the swelling of chorionic villi. There are several risk factors for developing a molar pregnancy. The first is when a fertilization event occurs at the extremes of age, either in a young teen or in someone of advanced maternal age, typically greater than 40 years old. Other risk factors related to the patient's gestational history include a prior history of gestational trophoblastic disease, a history of spontaneous abortion, infertility, or nulliparity. Lifestyle factors such as smoking and nutritional deficiencies can also increase the risk of developing a molar pregnancy. Specific nutritional deficiencies that have been associated with this include deficiencies in folate, beta-carotene, and animal fat. The most common clinical feature associated with complete molar pregnancies is vaginal bleeding in early pregnancy. The patient may also have a uterus that is larger than expected for dates on physical exam. They may experience excessive nausea and vomiting, which may be classified as hyperemesis gravidarum if it's severe enough. Patients may also present with preeclampsia at less than 20 weeks of gestational age, which is a pathognomonic finding for complete molar pregnancy. A patient with a complete molar pregnancy may also show signs and symptoms of hyperthyroidism, such as heat intolerance, tachycardia, and tremor. Finally, they may develop theca-lutein cysts on their ovaries secondary to the molar pregnancy. Several of the clinical features associated with complete molar pregnancies are due to the increased levels of beta-HCG that are seen secondary to syncytial trophoblast proliferation. This is due to the fact that the beta subunit in the structure of beta-HCG is analogous to subunits of other hormones, such as LH, FSH, and TSH. Therefore, the excessive levels of beta-HCG can cause the body to respond as if there were excessive levels of these hormones as well. This leads to hyperthyroidism, stimulation of the ovaries by gonadotropins, resulting in cysts, as well as hyperemesis. However, these are usually late findings in complete molar pregnancy because they require weeks of significantly elevated levels of beta-HCG in order to develop. When diagnosing a complete molar pregnancy, the most important lab to obtain is the beta-HCG level. In most complete molar pregnancies, the level will be greater than 100,000. In addition to the beta-HCG level, a pelvic ultrasound can also be useful. The appearance on ultrasound is often described as a snowstorm appearance, and this is due to the swelling of chorionic villi. There will be no fetal parts, no heart tones, and no amniotic fluid present. In addition, the patient may also have bilateral theca-lutein cysts on the ultrasound. These will appear as cysts with thin walls filled with clear contents on an ultrasound. This image shows the ultrasound findings of a complete hydatidiform mole. And as you just stated, these are sometimes described as a snowstorm appearance, or they may also be described as a Swiss cheese appearance. And this is due to the anechoic spaces which are visible, for example, right here and right here. And these anechoic spaces represent the hydropic villi. If a patient is presenting late during the complete molar pregnancy, they may experience the passage of grape-like molar clusters through the vaginal canal, which are the hydropic chorionic villi. However, this is uncommon in the US due to the early detection of complete molar pregnancies during prenatal care. After diagnosing the mole, other labs should be obtained. A CBC, type and screen, and coagulation studies will be important for potential complications of treating the molar pregnancy, such as hemorrhage or RH sensitization. A TSH level and a comprehensive metabolic panel should also be obtained to determine if the complete molar pregnancy has had any effect on other organ systems throughout the body. Obtaining a chest x-ray used to be common, but it's now recommended only to obtain a chest x-ray if the patient is experiencing pulmonary symptoms. This x-ray would be to rule out any potential metastasis that can occur if the molar pregnancy has become an invasive mole or is associated with choriocarcinoma, which we'll be discussing later in this lecture. The definitive diagnosis can only be determined after pathologic examination of removed tissue. When this tissue is examined, the pathologist can use a P57 immunohistochemical stain in order to distinguish between complete and partial moles. Since the complete mole only contains paternal genetic material, it will stain negative for P57. Here is an image which shows the hydropic villi that are present in a hydatidiform mole. If a molar pregnancy is not caught and removed early, the patient may pass this material through the vaginal canal. This is usually described as the passage of grape-like masses. All right, let's try a question. A 15-year-old G1P0 girl presents to the physician at 7 weeks of gestation, reporting severe nausea and vomiting for the last 5 weeks. She cannot tolerate either fluids or food. She used to weigh 70 kilograms before pregnancy, and now she weighs 58 kilograms. The patient has also experienced intermittent vaginal bleeding. The physical exam reveals a fundal height of 15 centimeters, and transabdominal ultrasound reveals the absence of a fetus. What additional finding will be found on the ultrasound assessment of this patient's pregnancy? All right, this 15-year-old patient presents with severe nausea and vomiting and intolerability to fluids or food. She's lost more than 5% of her pre-pregnancy weight, which is consistent with the diagnosis of hyperemesis gravidarum. She also has intermittent vaginal bleeding and a fundal height inappropriately large for her gestational age. Transabdominal ultrasound reveals the absence of a fetus, and all of these findings indicate the diagnosis of a complete mole. An additional ultrasound finding in a complete mole is the snowstorm appearance caused by cystic swelling of the chorionic villi. All right, moving on to management. The curative treatment for a complete hydatidiform mole is dilation and suction curettage. During this procedure, a uterotonic such as oxytocin should be administered after evacuation in order to decrease the risk of hemorrhage. If there is hemorrhage, the patient should be provided with a blood transfusion. In addition, if the type and screen reveals that the patient is Rh negative, the patient should receive RhoGAM to prevent sensitization. While dilation and suction curettage is typically the first-line treatment, if the patient has completed childbearing, they can also be offered a hysterectomy. If the patient has theca-lutein cysts associated with the molar pregnancy, there's typically no intervention needed, as these will regress when the beta-HCG stimulus is removed. If the patient has been experiencing medical complications of the molar pregnancy, they'll need to be treated. If the pregnancy caused increased blood pressure, the patient should receive antihypertensives in order to decrease the risk of stroke. If the patient was experiencing symptoms of hyperthyroidism, they should be prescribed a beta blocker prior to removal of the molar pregnancy to prevent a potential thyroid storm during the procedure. After the molar pregnancy is removed, beta-HCG levels will need to be monitored to ensure that there is no remaining tissue and that the molar pregnancy does not transform into malignant gestational trophoblastic disease. A quantitative beta-HCG level needs to be drawn on a weekly basis until it's negative for 3 weeks in a row and then monthly for 3 months. The patient will also need to use reliable contraception for several months because a new pregnancy can make the interpretation of beta-HCG levels difficult. The preferred method for the patient to use would be oral contraceptive pills or a barrier method. IUDs are typically not recommended due to increased risk of hemorrhage, infection, and perforation of the uterus. All right, now that we've covered complete molar pregnancy, let's move on to discuss partial molar pregnancy. A partial molar pregnancy is the result of aberrant fertilization leading to abnormal chorionic villi with trophoblastic hyperplasia. A partial molar pregnancy may also be referred to as a partial hydatidiform mole. In contrast to a complete molar pregnancy, a partial molar pregnancy is the result of fertilization of a normal ovum with maternal genetic material by 2 sperm. This results in a triploid karyotype with 69 chromosomes. This abnormal fertilization and karyotype leads to the hyperplasia of trophoblastic tissue, primarily hyperplasia of cytotrophoblasts. The risk factors for a partial molar pregnancy are similar to that of a complete molar pregnancy. They include the extremes of maternal age, a prior molar pregnancy, prior spontaneous abortion, and infertility. Partial molar pregnancies typically have a more mild clinical presentation than a complete molar pregnancy. A patient will typically present with delayed menses and a diagnosis of pregnancy. They may also experience vaginal bleeding in early pregnancy. However, in contrast to a complete mole, patients with a partial molar pregnancy will typically have a uterus that is small or appropriate for gestational age. Patients may also experience a spontaneous abortion in the late first trimester or early second trimester due to the chromosomal abnormalities present. Symptoms related to beta-HCG excess are rare in partial molar pregnancies. And this is due to the fact that a partial molar pregnancy results in the hyperplasia of cytotrophoblasts rather than syncytial trophoblasts. This means that the high levels of beta-HCG seen in complete molar pregnancy are not present, since the syncytial trophoblasts that produce beta-HCG do not experience hyperplasia in partial moles. Due to the lack of hyperplasia of syncytial trophoblasts in partial molar pregnancies, the quantitative beta-HCG level may be normal. On pelvic or vaginal ultrasound, there may be an abnormally formed fetus or fetal parts. There may even be fetal heart tones present. If there is a fetus present in a partial molar pregnancy, it may present with intrauterine growth restriction. Definitive diagnosis can only be determined after pathologic examination of removed tissue. When this tissue is examined, the pathologist can use the P57 immunohistochemical stain in order to distinguish between complete and partial moles. Again, as we discussed earlier, since the partial mole will contain both paternal and maternal genetic material, it will stain positive for P57. This image shows the histological findings of a partial mole. In this image, a large edematous hydropic villi can be seen. It's worth noting that in partial molar pregnancies, only some of the villi are edematous. Okay, moving on to management. Since a partial molar pregnancy may present with a fetus on ultrasound and fetal heart tones, the pregnancy should be monitored closely until it's determined that it's not a normal pregnancy. Once this determination can be made, the partial molar pregnancy should be removed by dilation and suction curettage. Monitoring of the patient after removal is the same as monitoring after removal of a complete molar pregnancy. Quantitative beta-HCG levels will need to be measured weekly until this is negative for 3 consecutive weeks, then monthly for 3 months. The patient should also use reliable contraception, such as oral contraceptive pills or a barrier method, in order to prevent an additional pregnancy that could make the interpretation of beta-HCG levels difficult. Here's a nice summary table that you can take a minute to review in order to solidify your knowledge of gestational trophoblastic diseases. All right, let's wrap up with a final question. A 21-year-old G3P0 woman presents to the physician at 5 weeks of gestation reporting intermittent vaginal bleeding. She had 2 prior spontaneous abortions. Her beta-HCG is 50,000. A transabdominal ultrasound shows a fetal trunk but no head or extremities. Some villi look normal while others look swollen. What is the best next step in the management of this patient's condition? All right, this patient with a past medical history of 2 prior spontaneous abortions is presenting with intermittent vaginal bleeding and a high beta-HCG level. A transabdominal ultrasound shows a fetal trunk but no head or extremities. Some of the villi look normal while others look swollen. Together, these clues are suggestive of the classic presentation of a partial molar pregnancy. The best next step in the management of this particular patient is dilation and suction curettage to remove the abnormal tissue responsible for all of the clinical manifestations. And that concludes our lecture on benign trophoblastic disease.